And now it's my pleasure to introduce to you Ricardo Costa. He's going to be the first operator for this also challenging case. And Alberto Cervoni. And also we have the chief of our cat lab, Dr. Sergio Braga. Ricardo, you're going to present the case.
Thank you, Fausto. So we have a case of 47-year-old female patient. As clinical presentation, she has presented with stable angina, now CCS2, but I have to say it's evolving over time and compromising to some extent her quality of life. As comorbidities, she has history of hypertension, dyslipidemia. Here the current medication she's taking, so she's under antiplatelet therapy plus medication to control her hypertension, enalapril, carvedilol, amlodipine, hydrochlorothiazide as diuretic, and simvastatin. As a lab test, nothing that calls the attention, has a normal renal function and a normal LV function with a previous transthoracic echocardiogram. Here, her EKG at rest, we don't see significant abnormalities. And she was referred for a diagnostic angiogram. This is prior to coming to our institution.
She's only 47 years old. How come the young ladies are coming with coronary artery disease?
Yeah, we're seeing this every time more. It has to do with the more exposure to risk factors, female patients, and unfortunately we are seeing these patients evolve with significant coronary artery disease and also acute events in a very relatively early phase. So she was referred for a diagnostic angiogram, as I mentioned, was done in another institution. It calls the attention already some degree of calcification, approximal LED. There's a mild to moderate disease in the first OM branch. There's some haziness at the very ostium of the LED. That's a place where the calcium. You see here a tight stenosis at the very ostium location. It doesn't appear to involve the circumflex. It doesn't appear to involve the ostium and the proximal circumflex as well, and left main.
So, but we have a bifurcation lesion here.
We have, by definition, a bifurcation lesion.
So how do you classify this?
By the median will be 0, 1, 0, considering LED the main vessel.
Okay.
Okay, so here we have the RAO. The OM is a moderate lesion. We didn't think it was very significant. Here you see the LAD.
Okay.
LAD is also a vessel with mild disease. There's the calcification there. Oops, just go back here.
So how do you classify the calcification in this case by angio? It's mild, moderate, or severe?
I would say moderate because you can already trace the vessel without the dye. Okay.
And
here, a LAO cranial view and another view. So just irregularity, some mild disease, not such a large RCA as well. So if you could summarize, Fausto, this is a single vessel disease, OM branch, but moderate, but significant lesion, proximal LED, also the LED involving the left main. So by definition, we consider this a left main bifurcation, as you mentioned. So we also had some scores here. It's a low syntax score. Both syntax 1 and syntax 2 recommend either PCI or cabbage. So the two, based on this recommendation, the two are okay. So here's the angio. We can see first the RAO.
So what kind of guiding catheter did you choose?
We choose a EBU 7 French to have a better support. Always when you're dealing with left main.
I saw you choose a femoral artery. Why do you not?
Yeah, she did the first angiogram by radio, and the radio didn't have a good patency anymore.
Okay.
That can happen in 5% of cases.
So that can happen with the small ladies, small arms. When you punch the radio, sometimes you can have occlusion of this artery.
Exactly. It's a predictor, yes.
Good.
So that's why we're here and with 7 French. So we see, I have to say, the lesion in the ostium of the L is not as bad as we saw in the angiogram here. In this first angiogram, here in the cranial view, you see the calcium. Here, maybe a little bit worse here, okay? It really, we have to say, this is a very critical location. And
so I would say 50, 55, before less than 60.
Okay.
So, does she have any stress test or?
She didn't have a stress test. She's only on optimized medical therapy and with worsening symptoms now, but it's a stable angina. This is the case.
Should we do FFR?
Also, it's always possible. It's a very proximal LAD, but this patient has symptoms. So she's already...
but young lady, usually they have symptoms.
Yeah.
They have some chest pain.
Yeah.
For this lesion, I don't know. Did you do IVUS?
We did imaging, okay?
Okay, let's see what
So-
you found.
And we didn't see the OM branch here as a significant lesion as well, okay? So now, if you could have the IVUS, please. Could we have the IVUS in the screen?
The Ostial.
So here we are at the level of the second diagonal, mid LED. Next
Okay.
one, you see the vessel here is about 3x2, 3x3 lumen, actually. Next one. Here's where you see the level of the septal. You see a tighter stenosis than you see by angio. It's calcified here. Next. Here you can see the proximal diagonal. Next. Here, the ostial location about 3.1 millimeter square. So this is the minimum lumen area at the very ostium of the LED. Next. Here you can see how the plaque extends into the left main. So we see the plaque does not end at the ostium of the LED. It ends at the left main, which is very common. Most of the cases are like that. Next. See, now we are coming one by one here in the proximal LED, in the left main. Next, just the plaque extend. And this is the left main. Distal portion of the left main is about 4.5. Next. And the proximal portion of the left main is about 5 millimeters square.
Okay, good. I have a suggestion here to you. Why can you just take a look in the physiological way, just to do a very nice demonstration? I mean, we have not prepared this, but we can do that because it is live.
That's
And
awesome.
then-
That's
and to-
precision PCI.
Okay, and to try
to
a
have-
correlation with area by IVUS, and also, do you agree with this?
Yes.
Physiological
Physiological.
assessment, do you?
Yeah,
So let's do that.
Absolutely. Let's
Okay.
do that. Yeah. So I'm proceeding here with the wire.
Okay. Now we're going to have the angel. Ricardo is advanced the system there. We have two wires, one in the LED and one in the circ. Are you going to keep the both over there?
Yeah, you can keep the wire in the circumflex, but I'm going to remove the wire in the LED once we
Maybe you can
cross.
just keep the wire in the LED because it's going to be easier to you
cross.
for being working of this.
Yeah.
And bring the wire back after you have the FFR wire in there.
Okay, so we just gave here nitro.
Uh-huh.
It's good to wait a little bit before we do the measure. Just wait a little bit because we just did the nitro. 30 seconds. So we are in a very distal position. We take all the myocardium at risk here in this anterior territory. Based on this
Can you
ostial lesion.
Can you bring it back, the guy wire?
Yeah,
I
we can
think
do
it's
the
okay.
pullback too.
Pull back.
Yeah, I think.
Because
Okay.
I think the tip of the wire is a little bit distal.
Yeah, we can
Then we would
pull
like
a little
to.
bit.
Okay?
Okay.
So the guiding catheter position should be engaged to the coronary artery or in the aorta?
Should be just at the ostium. If
At
you
the
don't have a
ostium.
disease left main.
Okay.
And I think we are in a good position here.
You are in a good position now?
We pulled back a little bit, yeah,
Okay.
from where we were before. Okay, so let's do the measure. So we do the non-hyperemic RFR from St. Jude. So it's 0.83. This is quite below the cutoff, which is about 0.89
Okay.
and below. It's always good to repeat this measure. Okay, 0.86.
So you have three measures, 183, 185, 86.
Yeah.
Do you think it's easily positive?
I think it's
Yeah.
quite positive.
Positive.
But we can do the pullback
Okay.
as well.
9.3 in the mid portion,
Uh-huh.
and we
You have 86 in
yeah, we will gain like 0.7.
Because you're taking all the full coronary bed
Okay.
that is related to that lesion. It does not impact only that proximal segment, it impacts the full territory.
Okay.
So that's an
So you
interpretation
think you
that we
should
do.
treat?
We think, I believe we should treat.
Okay.
So we don't have to try to recross
Can
again.
you do direct stent in this, or should we prepare the lesion? Since
That's
the
a-
lesion is not severe.
Yeah, it's not that severe. There's some calcification there. I thought we could have some preparation there because there's some degree of calcium there as well.
Okay. So are you going to cover
more
all the left
control S.
main with the stent, or
Control-
just restrict to the
Control
distal
S.
left main?
We thought about, it's a short left main, and we saw the lesion extending to the left main, so we want to cover the left main as well.
Or
And do
even the
port
ostium?
there, up to the ostium, yes. It's 6
Okay.
millimeters there.
So what size of stent you are gonna?
So the size of stent that we have there, we have measured and taken, let's say, the less disease segment based on what we saw by IVUS here. We pick a 3.0 by 33,
So
it
you're
can
gonna
go
do a
up to the
provisional
ostium.
technique.
Provisional technique, no
So if
stenting
the
plan.
circ is not okay, the result,
Yeah, we saw
what technique you are gonna choose?
it's provisional, so stenting, then optimize, do the pot, and then recross, do the kissing. Very
So if you don't,
gentle
if you don't,
implantation.
if you do not get a good result in circ, you're gonna do a tap, T in protrusion, or T, or
Yeah, if you need, yes, you do a tap.
what view we're gonna use to deploy the
Yes.
stent in the ostium?
We use this view to check your position, but to deploy, if you want to pick the ostium, you need to use the LAO cranial view.
Now we are inflate the balloon in the left main.
10, 12.
Need to be a short inflation,
Okay.
short time,
So into 12 here. Okay,
12.
okay, down.
and deflate
So now we can use the same balloon here. I'm just gonna,
without moving the balloon to check where you deploy the stent. Is that correct?
yes. So I'm pulling now the guiding catheter
Yeah.
with my left hand, and I'm pulling the balloon just to avoid the guiding catheter to touch the struts here.
Yes,
So I'm
very
pulling
important.
everything here. Okay,
So
so I'm out,
he-
and I'm using the same balloon here
Ricardo,
to do some
left
extra
hand.
post-dilatation, okay?
Okay.
Pode ir, subir, vai,
Now he pulling back the balloon,
vai, ok.
and we are going to up with
16.
16 atmosphere.
okay.
16.
Ok, down.
So you are just to optimize the result in the LAD. Is that correct?
Yes.
Okay,
So
good.
here I'm just pull the
Pull the
balloon.
stent
I'm
back,
bringing here
the
with
balloon
my
back.
left hand, very gently here,
Okay.
taking care with the wire distally.
So you need to watch
Test.
your guiding catheter.
Okay.
You don't want to touch the.
So we're
the
just going to
stent.
do a control angel here.
Okay. Good.
So we are fine. No compromise of the circumflex. So now
What is
we're
next?
going to remove, we're going to optimize the expansion of the stent in
So
the
you're going to
LED.
keep both wires,
Both wires.
circ and LED,
Yeah.
and bring a larger balloon,
Yes, 3.5 by 20.
3.5 by 20. You're going to use this balloon to optimize the
The
LED
LED,
stent too?
the LED stand.
okay LED
And then
distal.
distal.
Distal
And then
part.
we leave the pot for
Uh-huh.
later.
What's the size of the left main?
About between 4.5 to 5.0.
So this is the balloon is only for the LED.
The balloon is only for the LED.
So you're going to
I'm
use a
bringing from distal
4.5
to
balloon.
proximal, exactly.
Proximal
working from distal to
left
proximal.
main. You're going to keep the wires, optimize the left main.
Yes, I'll keep the wires.
Mm-hmm.
I just remove the circumflex when I recross if I decided to treat the circumflex.
Okay.
So I'm bringing now the balloon here, 3.5 by 20. So I can go across here very gently. And we start from distal to proximal. We're going to use here the Stent VS feature in this GE machine, just to make sure we are in the right position.
So you're using the
Tirar o peg.
stent boost. Huh?
Yeah, it's like a stent booster. So I like the position.
Yeah.
Okay, we're inside, okay, start.
You're 12 atmospheres now.
12,
14.
14,
A 3.5 balloon.
16.
16, okay. Down.
Okay.
There's some calcium there that we're not gonna be more aggressive than this. Now I'm pulling here the balloon and I'm pulling out the
Okay.
guide
So if you have good result with this 4.5 balloon in the left main, do you think we need to work on the circ with?
No, that's no answer about this. Some studies suggest you might have less restenosis. Some studies suggest if you now with the pot that if you have fully open, that might be okay. I tend to do it, but
Okay.
in a case like this, I don't see any compromise. Probably not do
Okay.
it. It's a good option. So I'm going here with a
Take your time.
5.0 balloon.
Uh-huh.
I have to be very
Perhaps this is gonna
accurate
be the
position.
final step.
Test. It could be the final step, yes.
It's a 4.5 balloon.
It's a 5.0 balloon.
5.0 balloon.
Test.
It is open, Ricardo. Can you close?
Oh, yeah. Test.
Okay.
Okay, so I like the position here. Go up.
So it's
10.
just proximal the bifurcation.
Yeah,
So you have a 5.0 balloon
Down.
inside the coronary artery in
we
the
did the
left
pot
main.
here. Yeah.
We went up to
12.
12 atmosphere.
And this
So
is
the balloon was fully expanded.
fully expanded.
So you're bringing back the balloon and you're going to do a
Control
test
engine.
now.
Okay.
Bring the guiding catheter. Okay, great.
So we like very much the position.
Uh-huh.
So Fausto, I think we're ready here to IVUS control. And
So it's better. Can you do FFR?
can do, yes.
Okay.
We can try to do
So
it,
let's
yeah.
do FFR. May we have FFR in the screen? And while they are preparing the IVUS, just to save time, Ricardo, can you do?
Yes, of course.
And after you take the balloon off, maybe you can just repeat the angel.
Yeah.
Okay, we are placing the guide wire exactly the same place we were before.
I'm going here in a septal here. Okay, so
Good. Now you
it's
got it.
better. I think it's a good position. Okay,
Yeah,
here?
good position.
Okay.
Just to have to align the.
Now you're going to measure. Is that correct,
Yes,
Ricardo?
we're gonna measure now.
Have the IVUS ready. Okay, we are waiting. Not measuring yet. How many minutes do you usually wait?
At least 30 seconds to 1 minute.
Okay.
That's what we do.
So we have been waiting for
At least, yeah.
45 seconds now.
I think less. I think like 25 seconds, yeah. You need to see
1
the
minute
screen
now,
and try
1
to
minute.
and try to have this,
We have been waiting for 1 minute now.
without. Okay, so let's measure
Let's measure.
IFR.
Let's see.
So 0.89.
89. It's
Next-
much
next
better.
one.
It was 0.83,
Yeah.
0.90. Again, measure again,
Next.
and go to IVUS, please.
Okay.
Okay. Good.
0.89.
Point
So we're
89.
gonna
So
do
you
IVUS.
did a good job. You went up from 83 to 89. So it's going to be not a very long run. We are going to be distal to the stent to see the ostial left main. Ricardo is bringing the IVUS now.
So we see fully open here according to the vessel size. We optimize here with a 3.5 by 20. Went up to 20 atmospheres.
Great. The stent is well expanded. So let's see.
Now we should be coming close to the
Yeah.
ostium. You see some degrees of calcification here. You see the entrance of the first diagonal, which is also good opening here by angel as well. So you see the wire here coming. You see the pot makes it very well opposed and open towards the circumflex, and here we are into the left main, just across, and I think we're just in a good position, taking the very awesome location.
That's great.
So
Great results.
we don't
Great.
feel like we should do anything else here in the circumflex, and I'm just going to do the final control angels here.
Let's do the angel, okay, and say
Just a minute,
goodbye.
just a minute.
Okay, bye.
Inject. Okay, great. Absolutely great. I congratulate you guys, our Professor Sergio Braga, and also the fellow here. It's Silvio Zampieri. He's using mask. I cannot recognize. Ricardo and Alberto. Great. Thank you, Medstream. Thank you, Samir Mehta, and all the organizers.
Thank you.
See you next Wednesday.
Thank you.
Bye-bye.